know the calcium is the marker of the extent of the coronary atherosclerosis, and calcification results in suboptimal results, impaired stent delivery, decreased stent expansion, malapposition, asymmetry, dissection, and perforations can occur, complication. So this registry tells us that the prevalence of coronary calcium on angiographic. We know that the clinical outcome by angiographic calcium severity, there can be a target vessel failure and death and myocardial infarction is more. So calcium is the final enemy for interventions. Severity of the calcified lesions is the limiting expansion is the main culprit. So we see there can be a discrepancy with OCT IVUS. Always for a calcified lesion, always prepare for the worst situation. A warning for the patient, strong guiding catheter, guide extension catheter if needed, and preparation of the atherectomy devices. So PCI for a heavily calcified lesion, the most important is lesion preparation, and the lesion preparation. Do not stent on poorly prepared calcified lesions. It can be done with high pressure balloon, angiosculpt, rotational orbital atherectomy, intravascular lithotripsy, and laser atherectomy. So this is a patient of calcified nodule where the Guidezilla support was taken, Corsair taken, Fielder XT crossed with Fielder XT wire. Then with the smaller and bigger balloon, there was a serial dilatation. You could see there was a post balloon, there is a diffuse multiple heavy calcified nodule, rotablation with 1.5 Burr. This is the post rotablation, and this is the post dilatation and a stent with the Guidezilla support, high pressure balloon dilatation up to 4 to 4.5, and this was the final angiography. So if we are using IVL, look for calcium breakage, or be cautious in a bifurcation lesion. Already we have seen one case where the calcified nodule shifted from, and in these cases, if we use modification, must be cautious about perforations in these cases. So the calcified nodules, they can be divided into eruptive calcified nodules and nodular calcifications. The eruptives are accumulation of small fragments of calcium with irregularities in surface and adjacent distal deep or proximal calcification, and non-eruptive is calcium fragment with fibrous cap which is smooth and thick with adjacent distal deep or proximal sheet of calcification. So clinically relevant, you can see this is the eruptive calcific nodule and a protruding nodule. These are the clinically relevant calcified nodules. The distribution you can see is they are seen in RCA, LED, as well as LCX distributed. And calcified nodules are generally located at areas of torsional stress. The calcified nodules are located within the sites of the dense calcium. So the calcified nodules you can see are generally in LED, RCA, or circumflex. There is there are the sites where there is dense calcium. So the rules of the nodules, they occur more commonly in sites of severe calcium and at the sites of torsional stress. So the pathogenesis of eruptive calcific nodule, the lipidic plaque occurs, then the lipidic plaque changes to calcified sheet, then the calcified sheet fractures at the hinge point, and there comes the eruption with an intraplaque hemorrhage. Then eruptive calcified nodule is deformable. It is called broken glass in a pillow. You can see these pictures. The eruptive nodule is seen in 5% of unstable ACS patients. Now the pathogenesis of protruding nodule, again there is a lipid plaque. The lipid plaque changes to calcified sheet, then the calcified progression to protruding nodule, and then the lipidic progression to protruding nodule. So protruding calcified nodule is a stable picture. The problem is that we cannot be differentiated angiographically and cannot be distinguished by intravascular imaging. The calcifying progression, the protruding nodule, and the lipidic progression produces the protruding nodule. So the protruding nodule, you can see in the diagram, it is deformable. It is called marble in pillow. So it is non-deformable. It can be non-deformable also. That is called marble in rock. So why can't intravascular imaging help? Because if it is superficial, you will be unable to see beyond it in the IVUS imaging. So the rules of calcified nodules, as I told you, eruptive calcified nodule are active and the protruding nodules are passive. So how can I differentiate? You can see the eruptive or protruding nodule is deformable, that is glass or marble in pillow, and protruding non-deformable can be there with like a marble on rock, where you will have a dog boning on the ballooning. Then the principles of treatment of calcified nodules can be used in non-compliant and a semi-compliant. Non-compliant balloon fare better. So these are the patterns of stent expansion you can see on the nodule. The concentric expansion can be there with glass in pillow, or the concentric expansion of the deformed nodule can be occur with marble in pillow, and eccentric expansion on non-deformed nodular calcification can occur as a marble on rock. So the calcified nodules, the principles of therapy, you can see the angiographic assessment. Then if the isolated nodule on angiography, there is no extensive calcium, we can take the help of NC balloon, or if there is full NC expansion, we can go, if required, can do IVL and get the goal. Or intravascular imaging, if there is a heavy calcium, there is or eruptive nodule, then again you can see for NC expansion, and then decide upon the further course of action for IVL, orbital, or ablative therapies. So the calcium nodules, nodular calcium is heterogeneous in response and look the same but behave differently in different patients. The principles of therapy, the calcium-specific therapies should be selected according to the individual lesion characteristics. The rotational atherectomy in calcified nodules is an ablative therapy, first choice for critical lesions and volume reduction. The larger the lumen, the more wire bias better. So you have to look for the wire bias towards the nodule. The larger the effect of the wire bias, the more variable the response to therapy, need a bigger burr. This is a case where rotational atherectomy actually failed in a case of calcified nodule. There was a wire bias which was away from the side of the nodule, so couldn't ablate the nodule. So this is a picture where the eruptive nodule was debulked. Then the orbital atherectomy can be used as ablative therapy. This is less dependent on wire bias. This is an example of orbital atherectomy being done. So this is how the deformed nodular calcification can be broken up with the IVL. You can see the calcium fractures on the IVL. So the IVL therapy is the lowest learning curve, safe, less restriction. Size to the vessel should be optimal, no effect on calcium volume, and there is encouraging early data. So this is a deformed nodular calcification, lipid-based fractures produced by, this is a case, I'll go quickly through this. This is a calcified LAD, and it was post-dilated, and the IVL was used in this, and a good final result. You can see the nice expansion after the IVL of the stent, and this was the IVS picture. You can see the calcified nodule and the these things. This is how the calcified nodule can be seen on OCT. And finally, the calcified nodule demonstrated a poor prognosis compared to non-calcified nodule even after ablation under the guidance of intracoronary imaging. Whether IVL helps is to be determined, but appears a useful potential future therapy. Thank you very much.